Good afternoon, dear colleagues. Today we will continue our webinars, our lectures concerning on drug medicine safety, and today we will talking about drug safety in children. And for our new participants, I would like to introduce myself. My name is Galina Cordero. I am medical doctor. I am qualified person of pharmacovigilance, head of pharmacovigilance department, clinical expert, pharmacovigilance expert, GCK, pharmac with scientific background. First of all, thank you very much for your attention. Second things which I would like to pay attention that now is very important time for organized pharmacovigilance courses. It will be international school of universal international school of drug safety, pharmacovigilance, medical affairs, where you can find all knowledge concerning on drug safety, pharmacovigilance, medical affairs. Why it's important and why I all time pay your attention, dear colleagues, because pharmacovigilance is now not activity but science, and even if this profession will be provided and you can get education in medical universities, still it's not enough, because beside of clinical knowledge, deep clinical knowledge, deep clinical academic knowledge of medicine, deep academic knowledge of regulatory science, it's not just GVP but regulatory topics, and it will be going not just clinical pharmacology science too, but still it's, for example, drug safety and R&D, drug safety and manufacture. I mean that you should know not just GVP knowledge, drug safety knowledge, but GXP knowledge, GCP, good clinical practice, GDP, good distribution practice, GLP, good laboratory practice, science of R&D, because majority of risk can go from R&D and from manufacturing too. It can be problems with logistic as well. Why it's important? Because pharmacovigilance and as a science now going on higher level of understanding of needs and combining knowledge, not just again practical knowledge, it's clinical knowledge, clinical science knowledge, it's internal disease, it's surgical, because when you see when you're looking for problems, you can find that majority risk can go from drug interaction, polypharmacy, drug interaction, drug-drug interaction, drug disease interaction, drug device interaction, and drug lens interaction, drug food interaction, and major aim of pharmacovigilance is find reason of risk and develop measures of minimization of this risk, plus to detect signal and working with this signal, and then if it's going to risk, minimize it too. Plus its knowledge concerning on GVP, good pharmacovigilance practice, how to build system, pharmacovigilance system, how to find mistakes, how avoid mistakes. Plus what I see from my clinical practice and my practice, 13 years working as a QPPV, head of pharmacovigilance department and clinical expert, major reason of problems can be medication error, medical error, and as a part of human factor is one of important. Why? Because if, for example, a medical doctor does not understand that it is important storage time, storage condition of medical drugs, and for example, if in SMPC has been reflected this drug does not open or open in just 12 hours, for example, and because if you don't do it, this drug can be contaminated as well. Plus another problems can be to find a reason to, for example, it can be another communal infection, and to find it reason and to minimize, because when you see I investigate this problem because I was interested in how it's connected, related. For example, another communal infection in hospitals with possible adverse reaction, and I can see that it can be a reason that disorder of rules of aseptic antiseptic can be problem, surgery, and even reason of sepsis in children, surgery sepsis, and you should know it. Why I pay attention? Because again it's combining knowledge from medical doctor science, healthcare professional, clinical pharmacology science, and from another side it's understanding regulatory side of GVP, good pharmacovigilance practice GVP, and guidance plus GCP, GLP, GDP, and all GXP rules as well. Thank you very much again for your attention, and now we will talk about drug safety in children. Importance of drug handling. Why drug safety in children is so important? Because first of all, you should remember that children is not young adult. Children has a special group with special physiology development, anatomical development, and when you dose and dosage form too. Importance of drug handling, including lack of data of important pharmacokinetic and pharmacodynamic difference, has led to several terrible situations in pediatric care. One is ethical issues and inability to obtain true informed consent. It's if, for example, we're talking about conducted clinical trials. The second obstacles is inherent to children. They grow and change rapidly. Infancy and childhood is a rapid stage of development, and various organs, enzymes, and body systems that handle drugs of their dosage and different in time. So, drug studies must be performed on children each stage of their development to determine appropriate usage. Highly critical aspect of child treatment care, peak kinetic parameter. It can be different if you compare with same parameter in adult population. Methods of drug administration and dose and dosage form. Drug safety in pediatric patients. Inadequate research data currently exists for prescribers to ensure a safe dosing for infants and children. Two sorts of drugs used in pediatric have never been tested in pediatric patients. Best Pharmaceutical for Children Act, you can find this document, and Pediatric Research Equity Act of 2003. 20% of drugs were ineffective for children, even though they were effective for adults. 30% of drug caused unanticipated side effects, some of which were potentially lethal. 20% of drugs require dosage different from those that had been extrapolated from dosage used in adults. And the laws were permanently reauthorized as part of the Food Drug Administration Safety and Innovation Act, FDA SIA of 2012. When we're talking concerning on a review of major issues related to drug safety in pediatric patients, concerning on drug safety pediatrics, what main reason can be of unsafety of drugs in pediatric population. First of all, it's adverse drug reaction. They can be, if you know, expected and unexpected, serious and non-serious, listed and unlisted, plus it can be divided different strengths, power from light stage, middle stage, and it can be serious stage of adverse reaction. As example, it can be different severeness of adverse reaction. For example, rash, it can be different, or for example, it can be allergic reaction, can be some not unsavory and going, it can be even anaphylactic shock. Medication error is second reason of unsafety in pediatric population. Off-label use of drugs and inappropriate and irrational drug use. What we know about exams, biggest problems, biggest tragedy is thalidomide tragedy, which happened in prescribing thalidomide drugs for pregnant women, and as a result were born children with phocomegalia, with not developing extremities and other teratogenic effects, and it was very huge problem. Before it was sulfanilamide elixir of death. Who know it? It was two tragedies where in its opening development of drug safety pharmacovigilance as important and necessary part of control of safety all drugs, and poorly development organ function and higher risk of toxicity and poor clinical response. It's a speciality of childhood and infant generally, because it's specific of this kind of population. Drug with higher tendency of adverse reaction in children included antibiotics, glucocorticoids, tuberculostatics, and immunosuppressive agents, anticonvulsant. And now, if you don't know, I can pay you attention, it's valproate tragedy where when pregnant women were prescribed with epilepsy valproate, and as a result its teratogenic drug was malformation, and valproate prescribed syndrome described in this group of children from these mothers. And vaccines. Children as a special group. Again, children are a special group because they are not simply small adults, but rather are dependent on age and other factors, biologic beings who absorb, distribute, metabolize, and excrete drugs differently from adults. Concerning on pharmacokinetics, there is high importance of clinical pharmacokinetics in optimization of drug therapy. Drugs that are safe and effective in one group of pediatric patients may be ineffective or toxic in another, so an understanding on variability in drug disposition is essential if children are to receive rational and appropriate drug therapy. Concerning on different stage stage absorption, distribution, metabolism, and excretion, this stage impact upon has some changes occurring in this group pediatric population. Changes in good pH after birth with a relative alcohydria until early childhood, decreased good transmit times in premature and terms newborns approaching adult values by 6-8 months of age, increased permeability to larger molecules in immature good mucosa, including in fact proteins that are not absorbed by a mature good. Immature biliary function and decreased pancreatic exocrine function impacts absorption of drugs with fatty chains, including prodrugs activated by enzymatic hydrolysis. This reaches maturity by 1 year. Distribution. Variation in body composition and weight with age affects volume of distribution. This direction of change in VD will depend on the physiochemical properties of the drug. Generally, water-soluble drugs, aminoglycosides, require lower doses with increasing age. Plasma albumin and total protein increases with age, reaching near adult levels by childhood. The availability of free unbound drugs will be partly influenced by protein binding. Metabolism. Microsomal protein content within the liver continues to increase until 30 years of age. Complex variation in the activity and expression of drug metabolized enzymes occurs both in utero and throughout childhood. Excretion stage. Renal function is around 25-30% of adult values in the term neonate. This increases to 50-75% by 6 months and reaches full maturity by age 2-3 years. Accordingly, total daily doses of drugs excreted primarily via kidneys must be reduced to avoid adverse reaction. We now going more deeply in stage. We're talking about first stage now, absorption. Two factors affecting the absorption of drug from GA drugs: the pH dependence, passive diffusion, and gastric emptying time. Other is GA drugs enzymes activity, pH premature infants, elevated pH more than infant, and infant range from 6 to 8, and gastric emptying infants neonate, prolonging gastric emptying time but lower peristaltic movement and older child and adults. In premature infants, absorption, higher serum concentration of acid labile drugs such as penicillin, ampicillin, and naphthalene, and lower serum concentration of weak acids such as phenobarbital can be explained by higher gastric pH. Gastric emptying time. Gastric emptying time is delayed in infants and reaches adult level by 6 to 8 months of age. Drugs that are absorbed primarily in the stomach may be absorbed more completely than anticipated. In case of drugs absorbed in the small intestine, therapeutic effect may be delayed. Peristalsis in the neonate is irregular and may be slow. Gastrointestinal enzyme activities. It is lower in the newborn than in the adult. Activities of amylase and lipase, beta-glucuronidase, and glutathione peroxidase enzymes are lower in infants up for 4 months of age. Neonates also have low concentration of bile acids and lipase, which may decrease the absorption of lipid-soluble drugs. Absorption from intramuscular route, less predictable absorption in infant, and exams like diazepam, rapid absorption, and phenobarbital, poor absorption. You should remember that phenobarbital in adolescents, besides of calming effect, relaxing effect, sleepy effect, can be cause of exciting of adolescent, and without relaxing effect you should remember too. Absorption from skin. Percutaneous absorption may be increasing in neonate because of an underdeveloped epidermal barrier, stratum corneum, and increasing skin hydration. Absorption from rectal route. The rectal route of administration can be useful in infants or children who are unable to take oral medication. The mechanism of rectal absorption is probably similar to that on the upper part of GA tract, despite difference in pH, surface area, and fluid content. We're now talking about distribution, and you should take into account total body weight. It's include 94% in the fetus, 85% in premature infants, 78% in full-term infants, and 60% in adults. Plasma protein binding less in newborn and infants, reasons, and it can be examples, and with this the decreases plasma protein binding of drugs can increase the apparent volume of distribution. What about metabolism in children? Drug metabolism is substantially slower in infants compared with older children and adults. Less maturation of various pathways of metabolism within an infant. And examples can be sulfation pathway is well developed and bus glucuronidation pathway is undeveloped in infants. The cause of the tragic chloramphenicol-inducing gray baby syndrome is newborn infant is a decreased metabolism of chloramphenicol by glucuronyl transferase to the inactivate glucuronide metabolite. Because of decreased metabolizes, doses of such drugs as theophylline, phenobarbital, phenytoin, and diazepam should be decreased in premature infants. Particular microsomal enzymes such as cytochrome 2C9, cytochrome 2C19, and cytochrome 1A2 are variant in their function. When we talk in elimination in children, the processes of glomerular filtration, tubular excretion, and tubular reabsorption determine the efficiency of renal excretion. These processes may take several weeks to 1 year after birth to develop fully. Glomerular filtration rate is about 4 milliliters per minute per 1.73 meter quadraticus in terms infants. In infants, it's possible they avoid chloramphenicol and aminoglycosides. because their metabolites are accumulated due immature function of kidney. Especially chloramphenicol metabolites are highly accumulated due to less developed glucuronidation pathways, which convert the chloramphenicol in highly water-soluble moiety. Monitoring parameters, vital signs, biochemical parameters in children. You see, it can be different. It depends on from age. For example, heart rate beats per minute. In age to 5 years, it's 100 and 120. And age, for example, 20 years, age 80, 100. Systolic blood pressure 80-90 millimeter hydrogenium volume is 80-90, and age 5-20 years 90-100. Respiratory rate beats per minute 25-30 from age to 5 years, and from age from 5 to 12 years it's 16-25 beats per minute. Albumin 50 in the age of 2 5 years, and age from 5 to 12 years is 35 55 gram per liter. Bilirubin milligram on milliliters, it's less than 15 age to 5 years, and age from 5 to 12 years is more than 17. Creatinine levels 30-80 milliliter in milligram in liter 30-80 from age from 2 to 5 years, and from age from 5 to 12 is 50-120. Hemoglobin gram on deciliter 11-14 age to 5 years, and from age for 5-12 years you see difference that in male it can be 13.58 18 in male, is 12-16 female, and you see this difference, and you should remember it when you prescribe drugs too. Concerning all those calculation, height and height and weight growth are rapidly changing factors in childhood, which also influence significantly some kinetic parameters. So these factors should be considered during therapy, so those calculation is needed. For many years, pediatric dosage calculation used pediatric formulas such as Fright rule, Young's rule, and Clark's rule. These formulas are based on the weight of the child in pounds or on the age of child in months and the normally adult dose of specific drug. Those calculations include formula, Young's rule based on age, pediatric dose are equal age multiply adult dose divided age plus 12. Fright's rule are adjustment for infants. Infants dose are equal age multiply adult dose divided 150. And Clark's rule based on body weight. Pediatric dose are equal weight multiply adult dose divided 150. Choice of dosage form, oral routes. Tablets are less convenient. Liquid preparation are easy to administer in accurate dose and to form is desirable dosage bulk dilution. Parental rule. Site of access, safety from fluid overload, and aware about excipients. Dose regimen selection. Dose regimen selection, you should take into account factors to be considered when selecting a drug regimen of route of administration for pediatric patient are age, weight, surface area. Assess the appropriate dose, assess the most appropriate interval, assess the route of administration, consider the expected response in monitoring parameters, interaction, legal consideration. Risk factors for adverse drug reaction in children include history of a previous adverse drug reaction, extremeness of age, impairment of liver or renal function, polypharmacy, female sex, certain genetic polymorphism, general anesthetic use, allergical anamnesis, and off-label drug use. And we are talking about risk factors which history of previous adverse reaction. Current accepted risk factor is history of previous adverse reaction, extreme of age, impairment of drug clearance, polypharmacy, female gender, higher drug dose, certain genetic polymorphism. Risk of adverse reaction in children. This problem is the use of label-use drugs exposes the child to a higher risk of severe adverse reaction. There is a lack of specific formulation in extemporaneous preparation, for example, when dilution concentrated in solution. The risk of medication errors is 3 times higher than those observed among adults. The incidence of error depends on the age of the patients, the therapeutic area, the setting, and the most cause it is due to the need to adapt. It is very simplistic manner, an adult dose according to the difference in weight and body surface of a child. Quoting the joint WHO UNICEF report, children are not small adults when taken in drugs. The capacity of absorption, distribution, metabolism, and elimination of a drug are very different between adults and children, and they continue to change during the stage of development. Because the pharmacokinetics in children is different from that in adults, the type and frequency of adverse reaction are specific to pediatric patients. The risk resulting from administration of a drug that has not been tested and proven in the pediatric population may therefore be due to overdose, increase in adverse reaction, ineffectiveness of the drugs for dosing, and use of a formulation was not appropriate. Problem and overdose drugs in children. A higher percentage of accesses to the emergency room of an adverse reaction after an ingestion on overdose of medication has been registered. The main causes of overdoses are accidental ingestion of the drugs for the lack of adult control, detective of inadequate packaging, for example, the lack of safety lock systems, the error in preparation, dilution, or more concentrated drug, includes the ingestion not being aware of same active ingredients in drugs sold under different name and different indication. One example that continually reach the RNF reports of adverse reaction in children is of overdose of oxatamide. There are 2 different packages of the market with same dosage form but a different concentration, O25 at 2.5, which shows an increasing risk of overdose linking to incorrect administration. Polypharmacy in the children. Polypharmacy is commonly defined in children, and when we are talking about children, you should remember that you should take into account special of development these pediatric groups. In contrast, polypharmacy has been reported as the use of 2 or more prescribing medication for children recently. Also, the increased risk may be extrapolated to children. Most reports on increased risk are limited to polypharmacy involving psychotropic medication or for psychiatric patients. There are few studies of the effect of polypharmacy of adverse reaction prevalence in children with various disease types. Using univariate analysis. One study conducted in Saudi Arabia demonstrated that the prevalence of adverse reaction in children less 15 years of age taking 5 or more drugs in hospitalized setting was significantly higher than in children taking less than 5 drugs. Another study conducted in Germany demonstrates that according to multivariate analysis, the prevalence of adverse reaction in children less than 17 years of age taking 4 or more drugs in non-institutionalized setting was significantly higher than the children taking 1 drug. However, these studies consider the effect of the health status, but not the effect of the disease types of enrolled pediatric patients. So also there are reports on the association of polypharmacy with adverse reaction in children. There is no report of analysis just to influence on concomitant disease types as confounding factors. Certain complicated disease with accompanying condition may influence the development of adverse reactions. For example, more adverse reactions are expected to occur in a patient with psychiatric or neurological diseases and cancer compared with others. Therefore, it is necessary to evaluate the influence of pediatric polypharmacy of adverse reaction after adjusting for the influence of various types of diseases. Information of this effect of pediatric polypharmacy of adverse reaction is essential for clinical practice because it's expected that a reduction in the incidence of adverse reactions will reduce the burden of patient and so reduce a medical cost. Problem of label use on unlicensed use of medicines in children. The off-label use on unlicensed use of medicine is a problem that is particularly important for children, also not limited to them. It has been estimated that about 70% of prescriptions in children are not off-label use of unlicensed indication, and the figures from hospital studies, also variable, are reasonably reproduced around the world. For example, in neonates in Italy, figures or about 50% have been quoted in Finland, 49% in Switzerland, 49% in Australia, 58% in the Netherlands, 32%. There are higher rates in younger than older patients in the hospitals than in the community. Pediatric unlicensed off-label use is particularly prevalent in neonatal and pediatric intensive care units and oncology wards. In primary care, the rates of unlicensed off-label prescribing may be lower. It was 33% in France, 29% a large survey in the Netherlands, 13% in Germany, and 11% in the United Kingdom in survey of 19 studies in children. The median rates of unlicensed off-label prescribing in hospital wards and the community were 51%, range 23-66%, and 21%, 11-33% respectively. Adverse drug reaction. Over 9% of hospitalized children have adverse reaction to therapy, and up to 4% of hospital admissions as the consequences of adverse reaction. Among the well-recognized patterns of adverse reaction is drug toxicity, of particular importance because of the relatively high risk for morbidity and mortality as compared to many other patterns of adverse reaction. The toxicity of many medicines in children is different to that seen in adults. Indeed, there are some groups of pediatric patients, such as babies in Natal Universal Care Unit, in whom drug toxicity appears to be quite common, 11-30%. Preference in adverse reaction between children, a difference in adverse reaction between children and adults. The response of children to medication differs not only in comparison to adults, but also between different pediatric age groups, neonates and adolescents. For example, premature neonates are unable to effectively metabolize and excrete chloramphenicol, leading to toxic plasma level and clinical picture described a gray baby syndrome. Child-specific factors, including frequent off-label unlicensed co-medication, limited pharmacokinetics (PK) and pharmacodynamic (PD) data, development difference in PK and PD, considerable variation in dose and frequency of administration due to a lack of pediatric PK data, is heightened risk of medication error may modify the risk of adverse reaction. Modeling and simulation can be used to support dose selection for pediatric studies and include existing safety data. Medication errors in children may or may not lead to adverse drug reaction depending on the type of error. The reasons of this are often multifactorial, including a lack of child-friendly formulation and insufficient training for health and care professionals. Furthermore, children's response to excipients may differ from adults and vary depending on the pediatric age group. Alcohol should be avoided in neonatal drug formulation. Pharmacogenetic risk factors may prevent at different times so-called childhood, and the overlapping development changes may lead to a similar clinical picture in children with different genotypes. Viral infections are more common in children. Upper respiratory tract is example. Viruses may interfere with the drug metabolism or modify the response of the immune system to certain medication as thereby cause of adverse reaction. The etiology and treatment of pediatric diseases is different compared to adults and may vary between pediatric age groups. Hypertension, epilepsy, and some diseases only affect children, retinopathy or premature bronchopulmonary and dysplasia. These differences influence risk factors and confounders for pediatric adverse reactions. In neonates and infants, PK and PD may change rapidly during the first few months of life due to organ maturation and changes in fat disposition and enzyme activity involved in drug metabolism. For example, infants and young children may be in higher risk of valproate-inducing hepatotoxicity. During puberty, hormonal changes may alter drug metabolism and response. Poor adherence and concomitant use of recreational drugs can be a risk factor of adverse reaction in adolescents. Drug reaction of drugs in newborns. A significant risk of side effect drug therapy in newborns, especially in premature infants, is associated with the immaturity of number enzyme system and mechanism of drug biotransformation and elimination. First of all, this concerns the immaturity of the microsomal mechanism of liver cells. The main components of monoxidase systems are contained in the hepatic cells of newborn is much smaller. Components of monoxidase system are contained in the hepatic cells of newborn is much smaller. Quantities in the adults. There are syndrome cytochrome P450 and not oxidase, cytochrome C reductase, uridine diphosphate glucurotransferase, as well as enzymes involved in the oxidation aromatic hydrocarbons. For example, in premature babies, the half-life of aminophylline 1000 hours. In adult patient is 6. A Gray syndrome is noted that develop in newborn when, again, chloramphenicol levomycin is prescribed. The low activity of enzymes that prevents the oxidation of cell membranes and the lack of vitamin E cause oxygen toxicity of newborns at concentrations that are safe for adults. In newborns, the renal clearance, as almost all drugs, is reduced, which makes it necessary to reduce dosages as a rule due to less frequent administration of drugs. Another important parameter for children in the first weeks of life is the ability of the drug to bind to blood proteins. Drugs such as sulfonylamides, especially long-acting ones that have a high affinity to proteins, can significantly increase the concentration of free bilirubin in the blood of child, which can lead to the development of kernicterus. Today, the use of these drugs can be abandoned. However, other drugs work in a similar way, such as ceftriaxone, which has to be used to several infections, in particular for meningitis. A previously little-known side effect of erythromycin in newborn was found in Tennessee, United States. 200 newborns were prescribed in due contact with a physician with whooping cough, while 7 of them developed pyloric stenosis, 5-fold increase compared to control population. Clinical manifestation of adverse reaction in children. Adverse drug reactions are great mimics of some diseases and may present, like in adults, with involvement of any organ system, including systemic reactions such as anaphylaxis. Multiple adverse reactions can be shown to one or more drugs and may cause a variety of symptoms in changes in laboratory values. Drug reaction may be caused by the metabolic and immunologic response of the skin. The most commonly affected organ system involved in adverse reactions are the skin of appendages, followed by the gastrointestinal system. The reaction may also be generalized. Involvement of other organ systems is less common. The most common dermatologic manifestation of adverse reaction is morbilliform eruption. Typically, an erythematous mucopollular lesion appears with 1 or 3 weeks after drug exposure, originates from the trunk, eventually spread to the limbs. Urticaria is typically a manifestation of truly allergic type 1 reaction, but it may appear with type 3 or pseudo-allergic reaction as well. Several non-allergic hypertensivity cutaneous reaction, erythema multiforme, Stevens-Jones syndrome, and toxic epidermal necrosis represent both skin diseases that require prompt recognition because of this association with significant morbidity and mortality. Eczematous lesions are most commonly associated with a topical medication and usually represent contact dermatitis, which is classified as a type 4 reaction to a drug exposure. The general criteria for the diagnosis of allergic adverse reaction include consistency of the patient of symptomatology with immunologic drug reaction, administration of a known drug capable of causing allergy, temporal sequence of drug administration, and appearance of symptoms consistent with the drug reaction, exclusion of all cause of allergic symptoms, and supportive laboratory data in keeping with immunologic mechanism or explain of drug reaction. Serious adverse reaction study, reaction safety signals in children, and nationwide database study. Children are more exposed to inappropriate medicine using consequent harms. Spontaneous reported of suspected serious adverse reaction increases knowledge and prevention of pharmacotherapy risk. Disproportionality measures are usable to quantify unexpected safety issues associated with a given drug and pair signals of disproportionality. This cross-sectional study aimed to assess reported safety signals for Brazilian children from 0 to 12 years old, notified between January 2008-2003 from the Brazilian Surveillance Agency. Nativity information from serious report gender was included. Disproportionality analysis based on reporting odds ratio with confidence interval of 95 was conducted to identify possible signals of disproportionate reporting. Almost 30% of 1,977 suspected SADR was related for babies from 0 to 1 years old. 69 of reports happened with intravenous dosage form, and 35 suspected SADR involving off-label use according to age. Why it's important? Why it's important? Because when you see analysis and assessment dates of database, you see that this group, pediatric group, is more sensitive group for development serious adverse reaction. You should remember too. And for example, pediatric specific adverse reaction for furosemide lysis, it's nephrocalcinosis, endometacin, indocin, renal failure, bowel perforation, adrenocorticosis, delayed development, growth suppression, tetracycline, discolored teeth, phenobarbital, hyperactivity, impaired intellectual development. It's, you still remember, is reaction atypical. What this means that you expect from phenobarbital increased sleepiness, relaxing condition, but and it's especially in adolescents you can meet hyperactivity, impaired intellectual development. Phenytoin, diplantin, thickened school course features, chloramphenicol, gray baby syndrome, phenyltiazine, extrapyramidal reaction, valproate acyl, hepatotoxicity, and aspirin, Reyes syndrome in patients with checkpoints or influenza. Reyes syndrome is more often syndrome in children, and most severe syndrome, it's hepatotoxic, it's even can get hepatic failure. Decision path versus off-label use in children and adolescents. When you prescribe information, you should read contraindication, dosage, information lacking, license checking, license alternative available, and prescribe licensing alternative. Off-label use possible, you should pay attention, contraindication specific to pediatric patient, dosage documented in literature guidance. Parents agree after being fully informed. Reimbursement by healthcare insurance, pharmaceutical directive, Annex 6. Compassionate use, permission granted for individual case, serious non-licensed treatment, justified expectation of successful treatment. It means that child are not small adults when taking drugs. Children differ from adults in terms of risk of particular adverse reaction because the lack of reliable data in pediatric population associated with specific problems including limited availability of safety data due to the lack of clinical trials in pediatric population, under of overdosing in some age group due to the lack of pharmacokinetics data or dose-finding studies. Maturation, growth, and development in the pediatric population susceptible to drug-inducing group, and development disorders as well as to related adverse reaction not findable in adults. And adverse reaction occurring early in life can additionally be accompanied by lifelong morbidity. Adverse reaction in therapy, some will note, it's tetracycline, teeth bone coloration, corticosteroid, growth suppression, and pubertal child, paradoxal hyperactivity in child with phenobarbital treatment, aspirin treatment, it can be again Reyes syndrome. You see this table, and what I want to pay attention that more clinical trials were conducted, were found adverse reaction. For example, when we're talking about problems which found with drugs, the talk baby powder containing 6.3 hexachlorophene in infants and young children in France, sulfonylamide elixir diethyl glycol using a solvent, and was 76 deaths, children and adults, United States. Vitamin E, emulsifertoxid neonates, 38 days. Paracetamol, diethylene glycol uses a solvent, 47 deaths, children, Nigeria. Paracetamol, diethylene glycol uses solvent, 51 deaths, children, Bangladesh. Magnesium sulfate concentration doubled, neonates, United Kingdom. Paracetamol 1998, diethylene glycol uses solvent, 85 deaths in children on Haiti. And you see that how can be a problem in sodium valproate, young children, hepatic failure. Was first its abnormal metabolism, that now we know that valproate sodium is contraindicated for pregnant women, and you should remember it too. Lamotrigine children's skin reaction can be associated co-medication with sodium valproate. Off-label use, the limited availability of medicine special design pediatric age. Less than why so frequent we today talked about off-label use, and now I pay attention that less than 15% of all drugs currently marketed and less than half of those specifically intended for children operated on the basis on clinical trials which demonstrate specific features or risk-benefit balance in children. Serious other reactions in children and adolescents can include dimethylhydrinate, deaths in fast doses, lines and dose exceeded, alpha-adrenergic nasal drops, coma and neonates. It's problems where overdose, dose exceeded, incorrect concentration administered, and it's a TC group, and many problems connected, related with when mother giving this drug for baby and not controlled dose. Phosphate-containing NMS, death in infants, contraindication in children not needed less 5 years. Angiotensin converting inhibitor, sartans, intrauterine damage, contraindication, pregnant women not needed. Methylphenidate, terminal liver failure, insufficient monitoring and long-term treatment. Liver disease in children, drug with high hepatic extraction ratio, more than 0.7. Such drugs include morphine, meperidine, lidocaine, and propranolol. Clearance of these drugs is affected by hepatic blood flow. A decreased hepatic blood flow is present in such diseases, status, cirrhosis, and congestive heart failure is expected to decrease the clearance of drugs with higher extraction rate. Theophylline clearance may decrease by 45% in a child with acute viral hepatitis. Because of lack of specific data on dosage adjustment in liver disease, drug therapy should be monitored closely in pediatric parents to avoid potential toxicity from excessive dosage. Renal failure. Renal failure decreases the dosage requirement of drug eliminated by the kidney. Once again, because of limited studies, dosage adjustment in pediatric patients are based largely on data obtained in adults. Serum drug concentration should be monitored for drugs with narrow therapeutic index and eliminated largely by a kidney For example, it can be aminoglycosides and vancomycin, including to this problem to optimize therapy in pediatric patients with renal dysfunction. For drugs with wide therapeutic range, penicillin, cephalosporin dosage adjustment may be necessary only to moderate to severe renal failure. Renal clearance or rate elimination is directly proportional to the glomerular filtration rate as measured by endogenous renal creatinine clearance 28 renal. Cystic fibrosis. Drug therapy in pediatric patients with cystic fibrosis has been reviewed. For some unknown reasons, this patient requires increasing doses of certain drugs. Studies have reported a higher clearance of such drugs as gentamicin, tobramycin, nitromycin, amikacin, diclocacillin, clocacillin, azlacillin, piperacillin, and theophylline. Reason variation in hepatic metabolic activities on phenotypic distribution of metabolic polymorphism may explain some pharmacokinetic difference in CF29C. Hepatotoxicity and sodium valproate. Hepatotoxicity in association with sodium valproate given as monotherapy is much more frequent in children. A majority of 100 patients who have died were children. The different relative risk between children on polytherapy and adults on monotherapy is 1 on 500 and versus 1 on 5,000. A retrospective American study shows that children under the age of 3 years were a higher risk group along with patients in polypharmacy as those with development delay. The mechanism of sodium valproate hepatotoxicity is thought to be related to abnormal drug metabolism, either reduction in fatty acid beta oxidation, the major detoxification pathway of valproic acid, and OH-associated increases in activity of specific syndromes. Cytochrome 450 responsible for the generation of putative hepatotoxic intermediates. This may occur as a specific vulnerable subset of patients on pharmacologic. Those with induced cytochrome 450 anti-activity consequent of concomitant treatment with carbamazepine, phenytoin, phenobarbital on pharmacokinetic basis. In contrast, there are some adverse hepatic events. They are more common among adults and children, notably infants and toddlers. And in an illustration, young infants tolerate paracetamol overdose much better do adults. The difference appears to be related on enhanced deactivity or sulfatotransferase isoforms relative to adults and possibly due to reduced activity of 5R4-reactivated cytochromes P450 capable of to produce the N-acetyl benzoxyamine intermediate during the first few months of life. Reye syndromes and salicylates. Reye syndrome was originally described in 1963. Children usually had a preceding viral infection, subsequently dosing, which led to coma, hypoglycemia, seizures, and liver failure. The association between Reye syndrome and salicylation had been raised as a possibility in 1965 by observant physicians who noted that 15 of the 31 cases reported had received aspirin prior to administration. In 1980, the association between Reye syndrome and the use of salicylates during the preceding viral infection was confirmed. Reye syndrome and salicylate. During outbreak of influenza E, 7 children were admitted to hospitals with Reye syndrome. The 7 children were compared with 16 controls from the same class who did not have symptoms compatible with diagnosis of Reye syndrome. All of the children with Reye syndrome took salicylates, whereas only 8 of the 6 controls took salicylates. The patient took a larger dose of salicylates compared to those in the control group, and the level of salicylate consumption was associated with the severity of Reye syndrome. The restriction of the use of salicylates for general anti pyresis of analgesia in children aged 12 and under has led to dramatic reduction in the incidence of rare syndrome in the particular patient population. The mechanism of the toxicity is known with respect to apparent interaction between salicylate pharmacodynamics and the multifactorial physiology abnormalities associated with viral infection. Metabolic acidosis and propofol. The children have developed several metabolic acidosis and lipemia. Many of the children were originally admitted to hospital with the upper airway obstruction and those were not expected to suffer multi-organ failure. The mechanism associated with the production of metabolic acidosis by propofol in children without concomitant hypoxemia is not known. It is, however, known that the dose of propofol used in children who died was considerably higher. Off-label prescription in children. The highest percentage of labels are registered in complex diseases such as cancer, cardiovascular renal disease, and hospital works corresponded to their therapeutic areas like intensive care, 36, 67 of children receive off-label prescription. In clinical practice, the outpatient prescription of off-label use is 11.37% of cases. Why it's important? Because it shows how important prescribe for children medicines according to SMPC, to Instruction for Medical Use. A systematic off-label use of drugs can be one of the main activity of the working group of the medicine in children and AFA working pediatric group. An updated list of off-label drugs associated with the availability of scientific evidence was put together and sent to relevant AFI Technical Committee of Science, CTC. ICH Conference, Harmonization and Clinical Medical Products on Pediatric Population. You should know this guidance. It's ICH 11, Guidance on Clinical Investigation of Medical Products in Pediatric Population to who conduct clinical trials. And European Union new legislation, it's creation of Pediatric Committee in the European Medicine Agency, requirement for pediatric data based of Pediatric Investigation Plan, PIP, for new products, as certain products already on the market are still under patent if this is done. An additional 6 months of patient protection may be granted for regular products of 2 years extension for orphan products. A new marketing authorization called the Pediatric Use Marketing Authorization may be granted given a 10-year period of market protection. A European database of pediatric clinical trials is to be created too. Data from pediatric clinical trials might be submitted to the regulatory authorities, and a European Pediatric Clinical Trials Network was set up along with new funding of off-patient drug studies. To reduce risk of harm from adverse drug events in young children, parents should use prescription and over-the-counter medicine only as directed, carefully give medicine as directed on the label or as instructed by the physician or pharmacist, make sure the safety caps are locked and the medication are kept in place young children cannot reach C. Identify adverse drug reaction. Assessing causality between drug and suspected reaction by using various algorithms. Documentation of adverse reaction patient medical records. Reporting serious adverse reaction to pharmacovigilance centers, adverse regulating authorities. Medication errors are defined as an available event prescribing, transcribing, dispensing, administration, or monitoring, regardless of occurrence of injury or potential injury. Such events can result from human errors or systemic defects. Types of medication errors in the children. Wrong medication, wrong dose prescribed or administered, wrong concentration or preparation error, wrong duration or frequency, drug-drug interaction, non-allergy to medication, omitted or duplicated medication, medication order not discontinued. Factors contributing risk for medication enrolled in children. Polypharmacy, multiply prescribing and multiply sites, cut delivery may use multiple pharmacies. Multiple caregivers administer medication school at home, frequently transition between health care setting, frequent change in medication and dose in response to fluctuation clinical status, different formulation routes on delivery, non-standardization concentration or liquid preparation of medication, uncommon medication or medication use off-label use indication, challenging with medication administration via gastrostomy or ionostomy tube, interaction among medication with different pharmacokinetic side effect profiles, potential renal hepatic impairment from underlying chronic condition or other medication, burden of caregivers to manage complex of medication regimes. Classification of therapeutic errors based on different phases of care. When we're talking in prescribing errors, it includes choice of the wrong drug, use unlicensed or off-label medicines, incorrect dosation of appropriate drug, wrong method of administration, inappropriate prescription, incorrect undurable, and lack of treatment personalization. When we're talking, it can be prescribing physician, ward physician, nursing, and relative caregivers, dispensing errors, failure or registers and administer a drug in the medical record, incorrect transcription of the administration drug's name and dosage frequency and time and administration, and administration errors, administration of the non-prescribing drug, wrong drug preparation, dilution, division of capsules, route of administration, frequency, time of administration, and inappropriate condition to administrated therapy. Thus, a medication role can be defined as a failure of the treatment process that leads or has the potential to lead harm to the patient. And you see that how many reasons can be of medication error. The treatment process involves all medications defined above. Medication errors can occur in choosing of medicine, irrational, inappropriate, and ineffective prescribing, under-prescribing, over-prescribing. Writing the prescription. Prescription error including eligibility, manufacture of the formulation to be used in wrong strengths, contaminants or adulterants, wrong and misleading packing, dispensing the formulation, wrong drug, wrong strength, wrong formulation, wrong label, administering of taking the drug, wrong dose, wrong route, wrong frequency, wrong duration, monitoring therapy, failing after therapy when requiring error alteration. Medication errors are also considered as an important cause of adverse reaction, should always be considered as a possible causative factor in any explaining situation. The incidence of medication error and the risk of serious errors occurring in children are significantly greater than in adults. Pediatric medication orders are more prone to errors than adult orders. Doses are not standard. Mass errors can occur when calculated the dose. Suspensions often have to be compounded. Tablets may have to be cut. Dilution need to be made to make amounts that are measurable. However, children have less tolerance and errors. Etiology of medication errors in pediatric population, you see that how many reason, and childhood obesity constitutes another opportunity for dosing errors. Birth weight, a premature required dosation dose interval adjustment, making this prescriptive administration phase susceptible to life-threatening errors. In addition, lacking standardizing doses regimen for children, most medication doses required calculations that increase the risk and impact of errors. The risk of medication error can even be increased because of the availability of different preparation of the same drug combined with diverse formulation for pediatric and adult administration. Variable prescription, frequent interruption, and lack of clinical pharmacists and care team are finally important risk factors of therapeutic errors. Why do we need pediatric pharmacists? Children are increased risk of adverse drug events, pharmacologic factors, age-based variability in absorption, distribution, metabolism, excretion of drug, physiologic factors, weight and body surface area need to be considered for each drug for each patient. Process factors, it's important factors which require needed pediatric pharmacists. It's individualized dilution of stock medication fluids, multiply concentration of same drug, dilution errors, environmental factors, weight, setting basic doses, error dosing rate. Error rate inversely related to size on weight of patient. Skills necessary. It's this kind of specialist should know dosage calculation, dosage form selection, specialized drug preparation administration techniques, understand the PK/PD changes occurring with age, understanding disease-specific condition affecting drug choice of dose, understand the nature of medication error in medication process. Patient. Medication administration dispensed. Administered and dispensing medication to pediatric patient entails a high risk to error when certain factors are not considered. Healthcare workers and pharmacists can lower the risk in the following ways. Pediatric safety or approval confirmation. Confirming which drugs are safe or approved for use in children is the first step in promotion medication safety. Pharmacists and other healthcare workers who oversee drug administration in the dispensers should ensure that all medication given to pediatric patients are considered safe and have been approved by the regulatory authority for its intended use. Confirming this information can help reduce risk of having children take medication that are unsafe and not improving. Dosing factors. When determining the proper medication dosage for pediatric patient, pharmacists and other healthcare providers should consider the following factors: patient weight, patient age, body surface area, clinically approved weight-based dosage range. When calculating pediatric medication dosage, especially for liquid medicine, weight is often used rather than age. Using weight-based range can offer a more accurate way to determine the correct dosage for children instead of basing dosage of age due to variation in body size of different ages. Utilizing body surface area to determine dosage and volume, consider a patient height and weight, which can provide a more accurate drug dosage. Appropriate dosage for improving pediatric medication safety and volume determinate the appropriate dosage from the different prescription medication. Pharmacists and other healthcare workers should determine whether a tablet of liquid form is more appropriate to pediatric patients. Several factors, including age, should be considered. Liquid form are typically used for infants and younger children, while tablet form may be appropriate for older children. Regardless of whether tablet of liquid form, the dosage should be accurate. Medication labels. Medication errors can occur due to unclear or incorrect information of labels. When determining the content of pediatric medication labels, pharmacists and other healthcare workers should ensure the following information is clearly stated: name of medication, when to take medication, how medication to take, proper storage instruction, possible side effects or reaction of medication, warning about allergic reaction to medication ingredients, what to do when a patient misses a dosage. Ensuring that all relevant information is included in the label helps decrease the risk of patient harm due to medication errors or adverse drug reaction. Side effects and adverse reaction. When determining the content of pediatric medication packaging and labeling, potential side effect or adverse reaction must be clearly communicated. This content should include a list of side effects, both common and rare, that may occur when medication consumed. Possible adverse reaction also need to be listed along with things and symptoms associated with the reaction. Pediatric medication labels and packaging should also provide clear instruction what to do in patients showing any signs of symptoms of adverse effects, such as contacting a physician or seeking emergency medical service. This helps to ensure the family members who administer medication to children know how to handle adverse event if one occurs. Hospitals and healthcare workers should also be familiar with the factors that may contribute to pediatric medication errors. Recognize these factors and avoid the same significantly reduce the risk of patient harm. Examples of this factor include the following. Do not abbreviate or shorten the name for medication or labels. Do not place a zero after a full number such as 1.0 or 2.0 since it can cause confusion about dosage amounts. Place a zero to the left of a decimal point if required, such as 0.1 or 0.2 milligram to avoid confusion over dosage amount. Role of pediatric pharmacists ensures the patient receives the necessary drug in a manner that allows the intended therapeutic effect to be realized. Patient interviews included information, medication history, inquiry about OTC and herbal medication, 2. Allergy history, true allergy reaction, immunization history, can make recommendation to MD if patient is not updated to or immunization, discharge counseling, administration, use of appropriate measuring device storage, dosage, preparation of form at home if necessary, attention to tests or liquid medication, prevention of accident ingestion, school day care is to directed patient and or caregiver. Drug information, influence selection of drug therapy, initial phase of patient care, consult with physician, patient, provide current and biased and irrelevant drug information, assist with finding literature supporting use of drugs for no-label indication. Therapy drug monitoring, understanding time indication of monitoring to prevent unnecessary blood loss on children, account for age-related difference in dosage, documentation patient chart, monitor steps of medication use process, reduce drug cost, avoidance of medication errors resulting from over or underdosing. For reducing medication errors, encourage others to report medication errors suspected other reaction, participation quality improvement committees, develop and enforce policies and procedures for safe medication practice. Error source measure to improve drug medication safety. Particular characteristic of pediatric pharmacology solution improve technical clinical pediatric pharmacology to that table database. Off-label use, good quality dose effect studies for medication outpatient in order to identify the age-appropriate dosage. Child-appropriate medication, awareness of license status of label use, development suitable form of medicine. Incorrect dose calculation, electronic drug safety testing, dosage database. Contraindication interaction, electronic prescribing system with decision support. Errors in transit, complete written, bad electronic ordering. Incorrect use, incorrect labeling, patient mix it up. Education, training, check as transfusion pharmacist on the word, barcode labels. Drug use evaluation, low therapeutic index drugs, those responsible for serious medication errors, higher frequency of preventable adverse drug reaction, expensive medication, education, persons, nursing unit staff, physician, and pharmacy students and residents. Drug safety tips for parents. Store medication in places too high for young children to reach or see. Do not leave medicine out after using them, such as sick child's bedside. Immediately return medicine to your safe-stored location after each use. Never leave children alone with medicine. If you are giving or taking medicine and you have to do something else, such as answer the phone, take the medicine with you. Never tell children that medicine is kindly to they take if your child does not like to take his or her medicine. Remind babysitters, house guests, and visitors to keep purses, bags, or clothes that have medicine in them or children's reach inside. When purchasing medicine, if you make children, check to make sure they are child-resistant packages they are comfortable using. Make sure the full rescue is kept each time for using medicine. Read all information on the package level, follow the direction. Do not give a child medicine more than often in great amounts as stated on the package. Use an only dosing device, oral syringe dosing cup, that included with the product. If his measuring device is not included with product or you do not receive one, purchase one at pharmacy and ask one from the pharmacy. A kitchen spoon should not be used to give medicine to children. Check the active ingredients prescription and over-the-counter medicine. Make sure that you do not give your children two medicines that have the same active ingredients. If you have questions, ask your doctor or pharmacist. If you do not understand the instruction on the label or how to use the dosing device or a single dosing cup, talk to your pharmacy and doctor before giving the medicine. And preventive strategy to improve the quality, safety of care, including pediatric population. Proposals to improve the healthcare quality, its exaltation of the importance of reporting adverse events, promotion of the current administration of drug indicated pediatric use, promulgation of computerized order entry standardized formulation of barcode drug, enhancement of research and clinical studies in pediatrics, sensitization of the ways of absorption metabolizing drugs during the growth, and increasing the awareness of the off-label use of certain drugs and potential related risk. The reducing errors and improving pharmacologic pediatric treatments, promotion of correct use of the drug in the pediatric field, as well as sensitization of population and healthcare professionals on possible risks deriving from administration of drug authorization for adult use, increasing of awareness of current off-label use of certain drugs and potential related problems, sensitization of the development variability of absorbing metabolizing drugs, emphasizing the importance of reporting adverse events, information of the value to research and clinical studies to improve the quality and safety of pediatric drugs, implementation of computerized order entry, standardizing formulation, barcode medication administration. Thank you very much, my dear friends, my dear colleagues, for your attention, and I will be thankful for your questions, for your wishes with topics which can be interesting personally for you. Please subscribe on my channel. It will help for increasing audience of healthcare profession, pharmacists, pharmaceutical industry professionals, and it will minimize as a result, minimize risks, medication errors. It will decrease amount of adverse reaction, because when you know reason of it, you will be informed. It will increase safety of patient, because we are from every how explain, we can be medical doctors, we can be healthcare professional, pharmacists, and everybody will take care of patient. Take care of yourself, my dear friends, and see you later on my future lectures. Bye bye.